Morning, good afternoon, everyone. It's so great to see so many familiar faces and a couple of faces I don't recognize. I can't wait to get to know you all. We are here for another Saturday virtual morning report where we do what we love, discussing cases, with the emphasis being on two things. One is recognizing that medicine is practiced globally in many different languages. And though our common language here is in English, we encourage folks to reflect in their own language, share a little bit about their culture. And the way we do that is through involving the chat and the conversation. So, believe it or not, that is not it. We have a special surprise for you. I love VMR so much, and I suspect that you are joining us on a Saturday because you do too. And we thought, you know what? Why not do VMR once, twice, 3 times, or maybe even 4 times over? So we are going to quadruple your dose of VMR today. And how we're going to do that is we're actually going to do 4 different cases in the next hour. 4, yes, that's 4. My dear friend Gabby was kind enough to set up a board such that we be able to do that. And the entire CP Solvers team has either thought really hard about it or has a case ready for you all. So what I'd ask you to do is contribute to the chat as much as you can and as quickly as you can. Why are we doing this? 1, I think we all love it, but we can take out a case and draw it out and talk about it slowly. But 2, more importantly, I'd say that this is what happens in real life. In real life, you don't see 1 patient in an hour. In real life, you see many more. And so let's start practicing for real life. Let's think hard and fast. And what's the ultimate goal? To be more prepared for that, but to ultimately teach us what is important diagnostically and what's not. Because when you don't have the luxury of time, you start to realize, actually, this lab is way more diagnostically fruitful than this lab, even though both are helpful. All right, so fasten your seatbelts. We're going to go in for one very fast ride. I don't know why I'm at. And our first case will be presented by the one and only Valeria. Do you want to unmute, introduce yourself, and jump right in, my friend?
Yes, hello everyone, I am Valeria, I am from Peru. You can call me Vale for short. And I'm really excited for today's VMR, it's gonna be great. I have a case prepared for you, so maybe the other case presenters can present themselves, like Gabriel.
Hi everyone, my name is Gabriel. Very excited to be here today with you guys. I'm from Peru too. You know, I am a very huge fan of the VMR community, and so just excited to see surprise of Ravi. It's going to be awesome.
All right, Gabriel, you want to say hi real quick? Actually, you know what, Vale, why don't we just jump in and then we'll have everybody introduce right before they present, okay? All righty.
Okay,
take it away, my friend.
Okay, so this is the case of a 34-year-old woman that was 40 weeks pregnant and came to the hospital in labor, referring intense chest pain with diaphoresis and dyspnea. She also was hypotensive and had an oxygen saturation of 89%. She also referred in her summary of the case that she had 2 abortions 4 and 2 years prior to presentation. And the first trimester of her pregnancy, she had hyperemesis. And she had diagnosed hypertension during pregnancy by the 21st week of gestation, but it was controlled. And so, yes, that's all I have for the first alloquat.
Amazing. Wow. Jump right in, not only with high velocity, but high intensity as well. Fernand has some amazing thoughts tuning in from Lebanon. Fernand, do you want to tell us more about what you're thinking? Oh, I think, oh, there you go. Hello.
Yeah, hi. It's 7 p.m. here. Yeah. How are you?
Incredible. It's great to see you. I was just talking to my mom who was in Lebanon, and now here I am chatting with you. I hope you're having a
Yeah.
great time there.
It's very nice weather. Like I'm towards the end of my vacation, so I thought I'll join you guys.
Absolutely. What better way to cap it? Where are you with this case? What are you thinking?
So I really want to rule out dangerous things, mainly problems inside the parenchyma, such as volume overload, because I can act rapidly on that. And this can happen in pregnancy when you have like elevated blood pressure complicated by preeclampsia, or problems that can lead to death, such as pulmonary embolism. And pregnancy, we all know, is a prothrombotic problem. The background of previous abortions, I don't know if they were spontaneous, I guess, is a little bit concerning for a tendency um, to clot maybe, or have a vasculopathy. So this raises a flag for maybe a higher likelihood of a vascular event inside the lungs. So these are the main things that I want to rule out.
Absolutely superb. Thank you so much. There's so much to digest here, and I think the chat is going on really just like on fire. And I'll summarize. Basically, we're recognizing that this is a cardiopulmonary emergency because of the chest pain, shortness of breath, and hypotension, and people are throwing out a lot of pregnancy-related or pregnancy-independent things. There's thoughts about making sure that we don't miss acute coronary syndrome as a possibility, and then layering within that, considering the usual causes of acute coronary syndrome, but also entertaining bland thrombus without plaque rupture with APLS, coronary artery dissection, which is much more common in pregnancy than otherwise. And then also thinking about amniotic fluid embolism, given the fact that she's in active labor, and then invoking hypercoagulability, wondering about pulmonary embolism. So the truth is, there's so many different thoughts that we should entertain here, but this patient is critically ill, and you're probably jumping to emergent management right away. I think one other key question is to try to wonder if there is an underlying predisposition to cardiopulmonary collapse, and that could be because of a prior unrecognized cardiac disease like pulmonary hypertension or mitral stenosis that leaves somebody who has the hemodynamic challenge of pregnancy superimposed. So we're really in a world where we're entertaining sinister causes of cardiopulmonary disease, prioritizing the prothrombotic state of pregnancy, the propensity for dissection in pregnancy, invoking a rare diagnosis of amniotic fluid embolism given the active labor, and we'll see where the next clues take us.
Great. So I only have the labs and then some imaging that to finish the second aliquot. So her white blood count was 15 with a differential of neutrophils of 66% and 1% of I don't know how to say it in English, but like the premature cells of the neutrophils, and her hemoglobin was 6. They also did some gasometry. Her pH was 7.32 with lactic acid of 3.2, CO2 of 42, and oxygen of 89. I also have a D-dimer, which was 1,000. And I have her prothrombin time that was 4.2. And thromboplastin time that was 110, which was elevated. Her creatinine was 0.89, and her albumin was 3. And all their metabolic panel was normal.
Were her platelets normal?
I don't have the platelets actually, but yes. Sorry.
Totally okay. And you said you had some imaging too, right? Is that
Yes, but I think maybe the imaging will be too technical.
Yeah, we'll save the imaging. All right, folks. So, Gabby is wondering if she's bleeding. I'll summarize the dimension that I think is striking the chat, and we'll wait for concepts, but for additional thoughts to trickle in. We wouldn't be surprised in anybody who's this critically ill to mount a neutrophilic leukocytosis, given how ill they are. And I think the surprising finding is the depth of the anemia and the uncovering of a coagulopathy. And so here, the anemia and the coagulopathy have brought folks to wonder whether there is a microangiopathic hemolytic anemia, and folks have wondered about the possibility of DIC. I think if you study the world of microangiopathic hemolytic anemia in the context of pregnancy, you have to consider every single cause of microangiopathic hemolytic anemia, like DIC, triggered by the usual stuff, but also triggered by obstetric complications, like Gabrielle mentioned, which is amniotic fluid embolism. TTP can occur in the context of pregnancy as the index presentation. So can hemolytic uremic syndrome. And then there's a microangiopathic hemolytic anemia unique to pregnancy, which is HELP, hemolysis, elevated liver enzymes, and low platelets, that is usually in the context of preeclampsia, which we were worried about here, given the hypertension. And as Fernando is mentioning, a catastrophic antiphospholipid antibody syndrome is also something to think about too. So we were entertaining mechanical things affecting vessels like dissection and thrombosis, etc. And now we have a hematological signature to the disease, and that connection may simply be because of overwhelming DIC from any disease process, or it may be that the hematological disease is the driver of all of this, in the form of a MAHA, which may be pregnancy exacerbated, like DIC, TTP, HUS, or pregnancy limited, like the eclampsia HELP spectrum. So I think that's where we're at. And folks are wondering about the baby, which is crucial in this circumstance, of course. And I'll pass the mic back to you, Valia, to give us the next set of data, and we'll probably reveal diagnosis, which we'll learn a lot from.
Yes. So I have some imaging I can share with you. So here it is. It's a CT. I don't know if you can see it. So I only have 2 slides. Sorry for the quality, but so here's the first one, and here's the second one.
All right, folks, do you want to call out what you see? I'll wait for the folks in the chat.
And honestly, I must say, the doctors I was case with actually didn't see it at first.
Yeah.
So,
Gurbani, do you want to tell us what you see?
I think I see a pulmonary embolus that goes through both sides of the lung. If that makes sense. A bronchus.
I fully agree. Valia, do you want to tell us what your interpretation was and what happened to the patient?
yes. So actually, I don't know if you can see that. Oh, what happened? That there was I don't know if I can share. Yeah, don't worry, I can share again. So here, this was this little line. It is what was the diagnosis? An aortic coarctation. I'm sorry, a dissection. And yes, this was very, very subtle. And at first we didn't see it, but it was actually what explained, and a thoracic a view of the CT actually showed with more clarity the coarctation. And so the patient had to go through surgery to repair this. Well, sadly, the patient died actually, but because she was very hemodynamically unstable. But yeah,
Tragically.
which I think is quite rare to see.
Yeah, tell us what you learned from this case.
So I actually, when I had this case, I felt very confident because from you guys I learned a lot from how to approach chest pain and prioritize the morbid causes of chest pain. And so I definitely from the start had coarctation and dissection, in my 4 causes that could kill the patient with chest pain. But just because the patient had all this all the history of spontaneous abortions and hyperemesis and preeclampsia possibly, I just kind of didn't prioritize it and went from some hypercoagulable state and didn't see the quotation, oh, sorry, the dissection in the CT. So I think that kind of biased me. I went looking for a thrombo in the CT and just missed that that finding. And so I think it's really important to just keep our differential broad, especially when the life of the patient is definitely at risk. So
I think it was amazing to see your own learning play out here. I think everyone in the chat was jumping onto the likely filling defect in the pulmonary artery. So what you learned is what we learned too. And maybe I'll slow down and take a minute to sort of anchor us in the two really important things, which is when you're thinking about chest pain, you really have to think about 8 life-threatening causes. And we break them down into 4 cardiovascular causes, 2 pulmonary causes, and 2 GI causes. And the 4 cardiovascular causes are the 2 A's and the 2 T's: aortic dissection, acute coronary syndrome, tamponade, and Takotsubo. And you can look at them, you can look at our schema on the website for more comprehensive analysis. But another dimension of this case, which I'll share the screen for a moment, is what can happen and what are the pregnancy unique complications. And this is an overwhelming Evernote. There's a lot on here, but I will focus you on the vascular and the thoracic. So just look on this side. You can see that there's a propensity for peripartum hemorrhage, but patients can thrombose in pregnancy for a variety of reasons, be it hypercoagulability in the lumen, a propensity for dissection, or because of amniotic fluid disease. And you all thought of that. But also there's a variety of other complications that can occur in the thorax, like peripartum cardiomyopathy or underlying disease. So know that patients with pregnancy are prone to vascular complications, either hemorrhage from a variety of reasons, or thrombosis, with many reasons to clot in pregnancy. And they can have vascular independent complications in their chest, be it peripartum cardiomyopathy, long QTC syndrome, and then some other things as well. So I think the takeaway is, in pregnant patients, prioritize vascular complications, which can range from luminal diseases to wall diseases to other. And then here you see some hematological issues that we touched on very briefly. Amazing. Well, thank you so much for a wonderful case. And I think, it's really hard to take a case like this and break it down. I see a great question from Felipe about, I see just the gist of it, which is how can patients with aortic dissection develop hypotension? And honestly, they can get every single kind of shock. So they can get a distributive shock from the sort of like the same reason you get neutrophilic pleocytosis is everything is ramped up. They can get cardiogenic shock from extension of the dissection into their coronary arteries. They can get obstructive shock from extension of the dissection into the pericardium, causing hemopericardium. And they can get neurogenic shock by extension of the flap into the spinal arteries, causing neurogenic shock. So the overlap between aortic dissection and shock is literally everything, every mechanism of it. Alrighty, whew. We really took quite a deep dive there. Gerline, do you want to do case number 2?
Yeah. Hi, I'm Gerline. I'll be presenting the second case. So this is a 75-year-old male with history of lumbar spinal stenosis who was transferred from a neighboring hospital for sudden worsening of his chronic lower back pain after he had a fall. It's sharp and achy, and the pain waxes and wanes, and also has some muscle spasms. He has a history of fecal incontinence due to IBS and has had urinary incontinence for the past couple of weeks that is new. No numbness or tingling. The CT scan and MRI at the neighboring hospital showed severe degenerative changes and severe lumbar stenosis, but the reports documented no signs of osteomyelitis. He had low-grade fevers, myalgias, and rhinorrhea several weeks ago, and then tested positive for COVID a few weeks prior to his presentation. Now he has no symptoms. His prednisone for his rheumatoid arthritis, the dose was increased recently for his COVID, for the COVID diagnosis. His past medical history is significant for rheumatoid arthritis, for which he's on leflunomide and prednisone. Also osteoarthritis, aortic valve replacement with a mechanical valve 12 years ago. He's on warfarin. History of AFib, coronary artery disease as well. No relevant family history. no smoking, drugs, or alcohol use. His vitals are normal on exam. There's no focal neurologic deficits on exam. There's some tenderness of the paraspinal muscles, but otherwise the physical exam is normal. I didn't examine the patient myself, but I was looking through some of the notes, and one of the notes does mention a systolic murmur, but I don't have more information about its characteristics. Initial labs were CBC was normal, CMP was all normal. The only thing abnormal in the labs was PT of 36.2 and INR of 3.2. And that's the first aliquot.
Ooh, what a doozy. Thank you so much, Gerline. And as Fernand said, congratulations on graduating. I'm going to pause for 10 to 15 seconds and see what comments come in the chat, and then we'll summarize them. So I'll hang tight for a little bit, and we'll see what folks have to say. Kushal, you have a really interesting thought. Do you want to tell us more?
Yeah, I would, with recent URI, I will definitely check for transverse myelitis, considering patient has incontinence. And also, I would be worried about coda equina as well. So I would get MRI spine.
Yeah, 100%. Do you want to tell us more about what you, your association of like what you understand about transverse myelitis?
Yeah, with transverse myelitis, I think you will get asymmetric weakness. You can get sensory level changes. So it all based on neuro exam, if you have noticed any sensory levels or not. And on CSF exam, you can find elevated IgG and increased protein, I think. Yeah.
Beautiful, beautiful. That's awesome. Thank you so much. And Nalan, you have some pearls about what paraspinal tenderness implies. Can you tell us more?
Yeah, hello. So hello everyone. My name is Nilan. So yeah, we had a similar case sometimes back in VMR, and I thought that maybe the disc prolapse has worsened and it's compressing one of the spinal roots, and that is causing the paraspinal tenderness as compared to spinal or midline tenderness. That usually implies a bony deformity or bony etiology. Here we have paraspinal tenderness indicating a paraspinal muscle spasm, which could be secondary to nerve root compression.
Wonderful. I love it. And for the sake of time, I'll move us on and summarize, and we'll get other folks' reflections in a moment. I'll kind of tell you the lay of the land for back pain, and then tell you, I think, what happens in real life, which is that when we say back pain, we almost immediately think of the musculoskeletal apparatus, namely the paraspinal muscles and the osteoarticular apparatus. But as you folks are alluding to, there's many other things in the back beyond the osteoarticular apparatus. And the things in the back are retroperitoneal organs like the aorta and the kidney. And then also the not just the vertebral column, but the actual spinal cord. So when we're approaching back pain, our approach is biased towards the mechanical apparatus that supports the spine, because back pain usually reflects benign disease of that world. But remember that you can have an aortic dissection present as back pain, and as Kushal reminded us, you can have a primary neurologic cause, namely transverse myelitis. So often I break that back pain into three categories: MSK, which can include vertebral osteo epidural abscess, primary neuro like transverse myelitis, or retroperitoneal diseases. And here I think that this in a patient with lower back pain, with a history of lumbar spinal stenosis who presents with sudden back pain, there's really no overt red flags absent the urinary incontinence. And so here the question would be, would you in real life do more for this patient apart from supportive care? And it's really, really hard, but the accumulative red flags are there's new urinary incontinence and there's new systolic murmur. And that combination of things in the setting of an aortic valve replacement really a prosthetic valve, I'd really worry about early endocarditis. And it's fascinating. In addition to everything else that was mentioned about getting an MRI, I think you have to wonder, is this patient have early osteomyelitis? And that won't show up on an MRI. And then you have to wonder, is the valve the problem itself? And so to summarize, back pain is usually disease of the musculoskeletal apparatus supporting the spine, but can be disease that originates in the retroperitoneum or disease that originates in the spinal cord itself. Early endocarditis resulting in osteo or epidural abscess can occasionally present as back pain with imaging findings that are initially negative. So keep your radar on for endocarditis in a patient with a prosthetic valve who has potentially a murmur. All right, Gurleen, back to you.
Yep. So MRI spine showed L3, L4 disc herniation, hyperintense signal on the L4, L5 disc with hyperintensity of the end plates. On day 2 of admission, the patient became somnolent. His blood pressure went down to 70s over 30s, 93% O2 saturation. A rapid response was called. CT head was done to rule out hemorrhage given that his INR was elevated. CT scan showed an indeterminate infarct of the right parietal occipital lobe. At that time, of the rapid response, he had a normal downgoing Babinski. He was moving extremities to painful stimuli. He also had an EKG, which showed new ST segment elevations, V3 to V5, with a troponin elevation to 39, and new wall motion anomalies on bedside echo. He went into sustained VTAC, was cardioverted, put on imudrip, and had persistent AFib afterwards. His labs at that time were significant for ProCal of 14, CRP of 135, INR of 6, an increase in white blood cell count, and lactic acid of 1.42. He was determined to be a poor cath lab candidate because of his comorbidities and his condition, so it was just medical management at that time. And I'll leave it at that.
Yeah, Gurleen, what are you doing to us? This is so intriguing. Kirtan, can I come to you to summarize the case? Like, what is the problem that you're trying to solve now? If you just come up with a problem representation.
Yes, so sure. So as you previously mentioned, that the fact that patient has recent onset of incontinence, and if you add the murmur to it, and now the given sudden decompensation of the patient, the SC segment elevation, we have to worry about that if it's indeed endocarditis, then we know that endocarditis can even shower the embolic showers into the coronary circulation, and that can explain the SC segment elevation. But we even have to wonder that what if it was something related to pericardium, because even constrictive pericarditis like pathology can cause diffuse SC segment elevation. So we have to be aware of that how to explain the SC segment elevation. And the end plate hyperintensities definitely makes us wonder that what if it is indeed osteomyelitis, because osteomyelitis classically in the initial stage presents as end stage hyperintensities. And given the fact that there was hyperintensity, we can even consider the possibility of abscess. It was not conspicuous on the examination, but maybe patient even has abscess. So all those things are going on my mind. And now help me, Ravi, how we can further elucidate this.
I think Alex has a great point about the INR. Alex, what are your thoughts?
Hey, everybody. So I just thought it was interesting that on initial presentation, the INR was 3 or slightly greater than 3, and we didn't have any other like CBC changes or CMP changes to help us localize that. And now that it's risen to 6 with this evidence of ischemic infarcts, I'd wonder if we had gotten a repeat CBC at that time, anything that might localize this to like a microangiopathic hemolytic anemia or some other reason why the INR is rising.
Beautiful. So well said. Stands on its own. Vale, I saw you had a really good thought up, actually proximal in the chat. Do you want to share what you're thinking?
Oh, well, I mean, I don't know if it is that relevant now with all these new findings, but I was thinking that the patient had the fact that had started or an increased dose of prednisone and maybe had chronic use of prednisone or corticosteroids, and that were predisposed to compression fractures. So without the other neurologic findings, that could be in the differential.
Beautiful. I think that is so additive, and I'll tell you where I'm at. We've proven that there is thrombosis here. We've proven it on the CT scan of the brain, and when you see ST elevations, you know that there's an occlusion somewhere in the coronaries to a high degree of certainty. And whenever all these schemas are on the website now, by the way, so I'll just summarize them. Whenever you have a thrombosis, you have to ask two very important questions: what and where? What is the humble recognition that not everything that causes a thrombus is actually bland thrombus? It may be pus that's causing the occlusion. It may be the deposition of cholesterol emboli from a cardiac cath. It may be tumor like atrial myxoma, and it may be calcium flicking off from a stenotic aortic valve. So what is important? And it's usually bland, but in the setting of inflammation, which we have undeniable evidence of here, you have to prioritize pus. Because thrombus plus inflammation usually means an inflammatory disease plus thrombosis, like a cancer plus clot, but robust inflammation plus thrombosis prioritizes a clot. Prioritizes pus, excuse me. So that's the what. The what is bland thrombus is the most common, but pus has to be entertained because of the inflammation. And then the next question is where? Where is the recognition that a thrombus can develop right there where you have a clot, like you have a DVT and the thrombus developed right there? Or it can represent the fact that a thrombus actually came from somewhere else. And that somewhere else is a recognition of the 4 places that are prone to causing diffuse embolic disease. And that is the venous circulation plus PFO. So a venous clot plus PFO causes showering everywhere. A primary valvular disease in the heart, arrhythmogenic disease like AFib, and then disease in the aorta causing showering of emboli everywhere. Here, there's no venous disease. Here, you have to entertain emboli because you have multifocal thrombotic disease. You have thrombus in the heart, you have thrombus in the brain, and maybe some disease in the spine. So you have to say, well, you know what? This could be a diffuse severe hypercoagulable condition like APLS, but more likely there's a clot sitting somewhere proximally showering the brain, the heart, and maybe the back. And that's where you have to really look at the heart and say, like, what is there a disease process happening in the heart? So we first proven that there's thrombus, and then we asked, what is it, bland or otherwise? And inflammation suggests pus. So we're worried about pus somewhere, and then we're like, there's multiple emboli in so many places, and so the common denominator is something in the heart. And pus plus heart prioritizes endocarditis. How can endocarditis cause back pain? Actually, 3 separate things. Vertebral osteo, epidural abscess, and most rare of all, a spinal cord infarction. Now, why am I saying spinal cord infarction? Spinal cord infarction is a painful condition that is MRI and CT negative, honestly. So here, what is the differential diagnosis of back pain? It's unrelated, and he has a disc herniation, nothing to do with what's going on. Or he has early osteo, early epidural abscess that Kirtan so eloquently outlined. But if the imaging remains negative, remember that you can have a spinal cord infarction that requires very close analysis of the MRI to see the evidence of the infarction. Okay, all right, I will pass the mic back to Gerline to take us home.
Yep. So blood cultures were also drawn at the neighboring hospital, and those results came back positive for Corynebacterium striatum. And then an echo was done at our hospital, which showed left ventricular ejection fraction 50 to 50%, segmental wall motion abnormalities, moderate aortic stenosis, and a mobile density on the right coronary cusp with some mild dilatation of the left ventricle as well. And then repeat blood cultures at our hospital also grew Corynebacterium striatum, I think in 3 blood cultures. So the final diagnosis was Corynebacterium endocarditis, and orthospine and a bunch of other services were also following the patient. And looking at the imaging, they thought it was more discitis of the L3, L4 discs based on the imaging. So I think it was the patient had a long and complicated treatment course. So I think like some things that I learned was that Corynebacterium is usually normal flora of the human skin and mucous membrane. So it's usually considered a contaminant when it is in blood cultures, but it can also cause endocarditis. It accounts for around 3% of cases. And the treatment has become more complicated with like resistance to certain medications. So this patient was initially treated with daptomycin, but the organism was resistant to that. And then there were persistent positive cultures. So then the patient was started on vancomycin, gentamicin, and then that was further complicated by renal failure and then maintained on linezolid afterwards. So just a little bit about Corynebacterium striatum. It can cause prosthetic valve endocarditis as well as vertebral osteomyelitis. And there's been, it's pretty rare, like some of the recent retrospective studies show that it's more common in patients who are like a mean age of 71 years, more common in males, and higher in hospital mortality is around 13 to 15%. And it's usually significantly higher mortality as compared to other species of Corynebacterium.
Yo, unbelievable. What did you take away as a reflection, Gerline, of what the initial presentation was and what the final diagnosis is? Tell us about that.
Yeah, I think this is one reason I chose this case, because I think in the beginning, I personally did not think about endocarditis. I was thinking more about the things we talked about just in terms of like the back pain, but like reflecting when thinking about it retrospectively, like the murmur on the exam and some of those, the other thing was like those chronics and like the myalgias and like the fever that he had a couple of months ago, if that was more of like a subacute course of endocarditis, since it was attributed to COVID. So I think some of those things just like retrospectively make sense, but I think in the moment, it's hard sometimes to think about. I guess it's important to not anchor yourself on when you think about back, not just anchor yourself on the most common or the most obvious things anatomically.
I think that's absolutely superb, my friend. You nailed it. A humbling case. You know, I recognize this pattern because I've seen it before and actually missed it in a patient with a prosthetic valve, and it's humbling to have that lesson repeated here. Folks, if you're like me, you're a little dyspneic from the roller coaster of high velocity, intense learning that we're having. So since we have 20 minutes left and we have 2 cases, I think we're actually going to pass on Maria's case to next Saturday and stick to 3 cases to slow down a little bit, reflect, and have folks ask questions in the chat and maybe present Gabrielle's case in the next couple of minutes. So I can summarize the first case and take us through the learning journey then and see what questions folks have in the chat. And that's when Vale presented a case of a young woman in labor who presented with essentially cardiopulmonary collapse. And we learned that all the causes of chest pain, 4+2+2, the 2 A's and the 2 T's, ACS, aortic dissection, tamponade, and Takatsubos, you have to think about all of them. But in pregnancy, it's important to prioritize vascular causes of disease. And pregnancy can affect the vessels by causing a propensity for hemorrhage, like peripartum hemorrhage or thrombosis. And in pregnancy, you can get thrombosis because of inherent hypercoagulability of pregnancy in the lumen itself, or disease in the wall, like vasospasm and dissection, or very rare entities like amniotic fluid embolism. Pregnancy also has effects on the heart with peripartum cardiomyopathy and congenital QTC issues, but most importantly, the hemodynamic challenge of that excess volume can predispose somebody with an underlying previously subtle cardiac disease like previously asymptomatic mitral stenosis or previously asymptomatic pulmonary hypertension. And then Gerline told us about a middle-aged man with back pain, and we reflected on how back pain can be a problem in the retroperitoneum, like the kidney, a problem in the muscle, in the spinal cord, like transverse myelitis, but usually a common in the vertebral apparatus, so the vertebral bones or the epidural. And we remembered all our emergencies, but reflected on how endocarditis can present with early osteomyelitis in the back that may not show up on initial imaging. And that was the humbling lesson here. And I saw that Raphael has asked why the patients have back pain. It is essentially early a pyogenic infection of the back, be it osteo or epidural abscess, that hasn't shown up yet. That's really what it is. So often when you repeat imaging in these folks, you'll start to see the initial findings blossom and become much more prominent. And Natalia, anything for you, my friend? I'll show it to you right now. It's not public yet, but for the VMR crew, here you are. So this is what we talked about, the vascular complications. I'll just leave it there for 10 seconds. There's many of them, but most pregnancy is great. Some pregnancy can lead to some problems. Okay. All right. We have 15 minutes for our last case. Any other questions, folks? All right. Last but not least, let's go.
I promise this is a short case. So this is a 60-year-old male from the Andes with a past medical history of cholecystectomy and diabetes mellitus type 2 that presents to the gastroenterology consult because of 1 month of progressive malaise, jaundice, and 10 kilograms of weight loss. And in the physical exam, actually it was everything normal: heart rate 88, respiratory rate 18, temperature 37, saturation of oxygen 96, and general, it was noted mucosal and conjunctival icterus, no cirrhosis stigmata, no edema. The abdominal exam was normal, neurologic exam was normal, no flapping, no focalization, and pulmonary exam clear to auscultation. And that would be the end of the aliquot one.
Incredible. Hans has had so many comments that have been so valuable. Tell us more here, Hans. What are you thinking?
I'm not sure about this case because usually it's more complicated. But when I see weight loss, then jaundice, my first thought was maybe it has to do with the pancreas. If the head of the pancreas is enlarged, it might obstruct the biliary structure.
100%. I think that's the most morbid hypothesis for sure. Amanda, I haven't heard your voice all hour long. Where are you?
Hi, everyone.
Hello. What are you, Amanda? What are your thoughts?
So I agree with Hans, and we have to think a pancreatic cancer because the symptoms and the age is very important in this case, I think.
100%. I couldn't agree more. I think when you're approaching jaundice, I'm going to something that one of the here, give me 1 second. One of our incredible CP Solvers team members, Kara Lau, made. Let me show you how to think about jaundice because you don't need me. Un momento. Okay. Let's just look at this together, okay? Where is it? Man. All right. Patient's jaundice. Is it direct or indirect? How do we know? We don't. We don't know for sure. We have to wait for the bilirubin. But when the patient's not short of breath because of hemolysis, it's probably direct. But we don't know that yet. And Kushal is invoking Oroya fever, which is a cause of hemolytic anemia, primarily because he's an ID nerd like no other. So we'll see if we're here or here. But odds are we're a direct hyperbilirubinemia. And then the next question is, what will the imaging show? And if the imaging shows blockage in the extrahepatic biliary tree, then we're going to go here. If the imaging is negative, we're going to go inside the liver itself and use the liver enzymes to guide us. So let's literally walk through this thought train with this case. So first, we need to know if it's a direct or indirect, and then we'll see what the imaging shows. So, Gabrielle, why don't you, without just tell, maybe we'll go off script a little bit. Can you tell us, just in the way this thought train outlines it, what's the bilirubin?
It's predominantly direct bilirubin.
Direct. Okay. So the next thing the thought train would tell us is, what is the imaging? What imaging do you have, and what did it show?
Okay. So the direct bilirubin was 5.4, and the ultrasound showed a common bile duct that was dilated with a hyperechogenic mass without acoustic shadowing on the inside.
Incredible. I'll pause right there, and then I'll give the mic back to you, but I want to show people where we're at. So 1 second, Gabrielle. So tells you got jaundice, it was direct, you took a picture, and now you have to figure out which one of these diseases. Is it a problem inside the lumen like a stone? Is it a problem in the wall like primary sclerosing cholangitis, or is it a malignancy? So Gabrielle, do you want to just share with us the full aliquot 2, and then we can start to analyze this case fully?
Mm-hmm. So the white blood cell count was normal, and for the sake of time, I will not say the differential, but it was pretty normal. The ESR was elevated, was 30, and the AST was 113, the ALT was 196, the alkaline phosphate was 1,870, and the lipase and amylase was normal. So the image of the ultrasound made us do a procedure because we suspected of something, and that would be the end of the aliquot 2.
All right, y'all. What do y'all think? I'm going to pause for Rafa. What are you thinking?
So I was actually thinking about primary sclerosing cholangitis because it increases the risk of gallstones, and this patient had a previous cholecystectomy, and also increased the risk of obstruction, but it could explain the jaundice. And yeah, so I think it's probably the next step is an RCP, just to see if there is the intrinsic dilation and structure, that this disease has.
I couldn't agree more. I think it's very, very hard to know and predict if you'll find a disease in the lumen, in the wall, or a compressive disease. And ERCP is a very good test to tell us where the problem is. You'll hear that a cholecystectomy is great for curing stones, but stone diseases can emerge from the stump of the cholecystectomy or originate in the common bile duct. So a stone, despite the cholecystectomy, is very possible here. A disease in the wall like a stricture from PSC is totally fair game. And compressive disease from pancreatic tumors, ampullary tumors is all fair game. How can you make progress? You really have to take a better picture. And I'm excited to see what that better picture is, Gabrielle.
Maybe Valeria can share the findings of the ultrasound. I'll send her an image. And then I will do the final aliquot. So sorry for the quality of the image, but it shows like a hyperechogenic mass inside a common bile duct and has no shadowing. And that is characteristic of, I would say, the final diagnosis. Is Ascaris lumbricoides causing biliary duct obstruction. And yes, the double wall sign. Some authors say that trail sign. And one interesting fact that I learned with this case is that one predisposed factor for getting Ascaris lumbricoides, a common bile duct obstruction, is a previous history of cholecystectomy. And I was wondering why. And this is because it it has been proven that patients with cholecystectomy have higher levels of TCK released post-meals, and the higher levels of TCK relaxes the ori sphincter, and that predisposes to an easier migration of the parasite to the common bile duct. Having that past medical history with a predisposed factor that the patient was from the Andes, yeah, it was Ascaris lumbricoides was one of the things we thought.
Oh, wow. That is absolutely amazing. So I summarize, higher levels of CCK status post-cholecystectomy open up the highway for ascariasis to sneak into the common bile duct, causing biliary obstruction. That is such an incredible case. I'll share the screen to show you something. Because when we're, we know the image in the thought train localizes the disease to extrahepatic obstruction. And the question is it in the lumen, in the wall, or is it external compression? And here the ultrasound was really good and told us that it's actually the problem in the lumen. And the lumen can be from the stone, from sludge, or a parasite. But remember that parasites can cause, the parasite plus extrahepatic cholestasis story is complicated because parasites can lead to stone formation, brown pigment stones, and parasites can lead to strictures, and parasites can occlude the lumen by themselves. So remember, stone, sludge, and then parasites are very common. Biliary cast is only in post-transplant patients. Wow, what an hour. I would love for us to go back to our case presenters in that order. So Vale, Gerline, and then Gabrielle, to re-emphasize your biggest learning point from your case today. And with that, we will conclude.
Yes, I really, really enjoyed this new format for VMR. I think it's brilliant. And well, for my case, I think it is important to always remember the rule of 4 + 2 + 2, just to prioritize the kind of more morbid and never miss causes of chest pain in a patient. And also, as Ravi mentioned, the complications that come with pregnancy, and in this case, prioritize vascular pathology. And yeah, basically that. Thank you so much.
Yeah, I really liked today's format. There was a lot of learning. So for my case, I think the biggest take-home point was to keep a high suspicion for endocarditis in patients with prosthetic valves, since it's such a sinister cause of a lot of things. So I think that was just like the biggest takeaway point. And the other thing was when you're approaching back pain and endocarditis, things to think about include vertebral osteomyelitis, epidural abscess, or spinal cord infarction.
Thank you, Ravi, so much for this day. I learned a lot, especially from the cases of Vale and Carlene. And my principal takeaway point I already stated, but reemphasize the important fact that we have to take in consideration who the patient is. Because in this case, the patient that was from the Andes have predisposed factors for Ascaris lumbricoides infection and the previous history of cholecystectomy, and the ultrasound findings was suggestive of Ascaris lumbricoides. And it's very important to treat it because if left untreated can lead to serious complications such as pyogenic cholangitis, pancreatitis, etc. So thank you a lot, guys.
Yeah, absolutely brilliant. Thank you all. I really, really enjoyed this, and I hope you did too. Two things to put on your radar. One is that the podcast recording that we did a couple months ago is going to be featured on the podcast platform in the near future. So if you were part of that, you might hear your voice on the podcast next week or the week after. And we're going to try to do this a little bit more frequently if people like it. So if you did enjoy this format, please consider presenting a case. And because it's helpful to know in advance, if you have a case to present for next week, please email us. And I just put in the email in the chat. So if you have a case for next week, please volunteer to present it. Maria worked very hard to, Maria, Gabby, and really everybody worked. I only saw Maria and Gabby, but I'm sure other people were helping too. It's a lot of work to put this together, but yeah, Kushal, you can totally make up. The case doesn't have to be real. The whole point is to learn, so you can totally construct a case based on a learning point that you have or a diagnosis you've heard about or anything really, which is maybe, Kushal, your only way of getting Oroya fever on here is you might just have to make it up. But yeah, if you have a case, real or not, email us, and we'll have 3 next time, including a case from Maria, which she was going to present if she is here next week. All right, y'all. Happy Saturday. Have a wonderful day, and hope to see you around.